Good evening, everyone. As Chairman of High Cancer Care, it's my great pleasure to welcome you to 2024 Natalie Shipman Memorial Lecture. And I'm delighted to extend a warm welcome to our two guest speakers, Judy De Winter and Dr. Jonathan Siv, and to Dr. Adrian Tuchman, who is High Trustee and Chairman of our Medical Advisory Panel. Thank you very much, all of you, for being here tonight with us. Being online is really one of these miracles that somebody of my age is still saying it's fantastic. What it means is that we can reach literally all over the world, and we have people joining us from across Europe, even America, Canada, and Israel, where, of course, our beloved Susan Shipman, who's Natalie's mother, is joining us from Jerusalem. Susan, we're delighted that you're here tonight with us, definitely in spirit. So allow me to give you a bit of an update. This is always a time when I use the opportunity to tell you what's been happening at Chai lately. So over the last year, we have we're supporting just over 4,400 cancer patients and their loved ones from age 3 to 99. Our oldest patient just had her birthday a couple of weeks ago. And we had the largest number of new clients in this year, 1,039. And those of you who heard me speak before will know that I always say that with a very heavy heart, mixed feelings, because I know I speak for everyone that we wish there wouldn't be the need. But whilst there is, Chai is here. We provided just over 22,000 individual appointments and group sessions. And we're currently working in 19 primary and secondary Jewish schools and non-Jewish schools across the UK. We know, sadly, that cancer doesn't discriminate by age or socioeconomic standing. A young, fit, healthy, conscious person can still be affected, as we saw from the Princess of Wales, who spoke so movingly recently and really brought the subject to everybody's attention. But this isn't news to us. And in fact, we've seen a marked change in demographic of our clients, with 1 in 3, that means 1 in 4,400 clients is now aged under 50. And to meet the specific needs, we have developed more group sessions, understanding the power and value of being with others who are in a similar experience and sharing those thoughts and what they've gone through. And in particular, I just want to flag up 2 new groups. One is a young adult support group, and one a loss of a parent bereavement group. And these are specifically for people in their 20s and 30s. And in fact, there's been a rise of 43% amongst all the support groups that we are providing now at Chai. And I also want to highlight and give you all an update on the NHS Jewish BRCA testing program, which launched officially in January this year. There's been a phenomenal response beyond, I think, anybody's expectations. And to date, I'm going to check the number, just 23,683 people have signed up through Jewish BRCA online to express their interest to be tested to find out whether they have the mutated BRCA gene. This is a very complex issue. And it is a very individual choice as to whether a person wants to be tested, if it's the right time for their lives to be tested. And what Chai and Together with Genetics, we were both organizations were appointed by NHS England to raise awareness of this really groundbreaking population testing opportunity. As I said, it is complex, and anybody who wants to have more information to please contact Chai, because we have counselors who are specifically trained to guide and advise and help the person come to make what is the right decision for them. But the fact is that this groundbreaking scheme, a pilot scheme, has the potential to save lives. So it is something for everybody to make an informed choice, and Chai is here to help people make that choice. Of course, my role as chairman and basically fundraiser for Chai, I can't let this opportunity go by without telling you all about the Focus campaign, the match funding campaign, which is on the 1st and 2nd of December, please God. Last year's campaign, in fact, the last few campaigns have, thank God, enabled us to carry on meeting our 3.8 million running costs per year. We never want to have to turn anybody away and not be there for them because we don't have the funds. And through actually it's a whole weekend. We're actually starting the whole weekend. The fundraising weekend is starting on Thursday night with a whiskey event. Anybody who's interested, please let Jamie know. Afterwards, just email. It's going to be a fantastic event in central London. We have Mad Hair Day on Friday, which is going to be in, I think, almost 20 schools, primary schools across the UK, where children come with crazy mad hairstyles. What's the point of that? Is to try and break the taboo that exists when perhaps mummy or auntie or grandma comes to school and maybe has lost their hair or is wearing a scarf. It's, again, one of Chai's educational tools to be able to talk about cancer and try and remove some of the taboos that still, understandably, are still there. Then we have the Chai Shabbat. Last year, I spoke about that first year. We had our little whiskey L'chaim cups. By popular demand, we've made them almost double size because people said they weren't big enough. So I know last year, many of you contacted us to say, how can we get these Kiddush cups, these whiskey cups? So please contact us. And of course, there'll be many communal events across the weekend. And last but least on this subject, we would really welcome if anybody's interested in becoming a team host. It means sending out a few messages to your friends, to your contacts. As the advert says, every bit helps, and we need to get to that 3.8 million running costs, our budget this year. So I thank you in advance for anybody who will come back and want to be involved in some way. A housekeeping note, of course, anybody, we would like feedback so we can plan next year's or any other lectures. And if anybody would like a CPD certificate, please email Jamie Hertz, who did send out the link for this evening's lecture. So this is the Natalie Shipman Memorial Lecture, and I'm conscious that we have many new people who have signed up to here tonight from Judy and from Jonathan. And whilst in my mind, it's 34 years since Natalie passed away, but I don't even have to close my eyes. I can still see her. I can hear her bubbly laugh. And I wanted to share this picture. And so some of you who didn't know her would have just a little glimpse. Of course, it's just a still, it's a, you know, a photo, but this little young lady, cannot say it strong enough. I had the privilege to be there when my mother met my mother, who's a co-founder. Mother Frances Weingarten was a co-founder with Susan Shipman. It's a hot June night. Natalie was in the last few months of her life. She was sitting in the garden when we met, and she heard my mother and Susan talk about their plans to create an organization to support the cancer needs within the Jewish community. And her little voice piped up and she said, "Mummy, I really want to help. What can I do?" Well, sadly, Natalie isn't here physically. She endured 3 years of grueling treatment, surgery, chemotherapy. She had the whole gamut. And she sadly passed away just before she was 8 years old. But her dynamism is still there. She still propels us, all of us who knew her, all of us had the privilege to know her. And the fact remains that through her, tens of thousands, if not even more, people have been supported through Chai. Chai has also been the catalyst to try and remove the taboos around cancer. And we've been, really blessed with the most fantastic support from the medical profession, from loyal donors, in every way, the most wonderful team. And I want to pay tribute tonight to the most fantastic Chai team, each and every one totally devoted, totally committed, and never saying no if they possibly can, to do our utmost. So Natalie, dearest Natalie, is always with us as this inspiration. And it's good once a year to be able to actually articulate that. And Susan, we wish you, of course, those long life. We wish you the happy memories should be the strongest in your mind of Natalie, and through her, what has been achieved these 34 years. And now it gives me great pleasure to introduce Dr. Adrian Tuchman, wonderful friend to Chai, a great advisor, and again, I will use this expression, a true mensch. Adrian, over to you. Thank you, everyone.
Thank you, Louise, and thank you all for joining us this evening. So very briefly, I'm a retired palliative medicine specialist, palliative medicine physician, worked at the Royal Free and the Marie Curie Hospice in London. I've been working with Chai really since its implementation, and I currently chair their medical advisory panel, and I'm a trustee for Chai too. know the organisation very well, and we are privileged and honoured tonight to welcome Judy De Winter and Dr. Jonathan Siv. So Judy De Winter was chairman of the Myeloma UK Board of Directors, and then she became the president of Myeloma UK. She will tell you about her illness and her problems and why she's doing what she's doing. But important to say, she's a very strong patient advocate. She speaks at national and international meetings as a patient advocate. And as I said, Judy will tell you a lot about herself and where she feels things should go in the future. Jonathan, Dr. Jonathan Siv is a consultant haematologist, associate professor at the University College Hospital London, where he was the clinical service lead for myeloma, and he'll tell you a little bit more about what he does. So we are privileged to have Judy and Jonathan speak tonight. Please, if you have any questions, put them in the chat box. We will do our best to answer the questions, and our plan will be to wind up at 9 o'clock this evening. So let me just hand over to Judy. Judy.
Thank you, Adrian, for your introduction. It's an absolute honour to be giving the annual Natalie Shipman Memorial Lecture this year. So thank you to Kai as well for inviting me and Dr. Siv to give the lecture this evening. So tonight's lecture, as you know, is about how empowering patients can transform cancer treatment and care. And although we are going to be focusing on myeloma and Myeloma UK, I see this more as a case study that you could apply to any cancer. We're going to be using my journey and Myeloma UK's journey to discuss some of the challenges that we've faced and how, with a very patient-centred approach, progress has been made possible. Now, those of you that attended last year's Natalie Shipman Memorial Lecture would have heard Professor Ruth Plummer talking about taking cancer drugs to patients and speaking about the importance of clinical trials and the importance of working in partnership. So our lecture this evening addresses that actually in quite a significant way, but from a different perspective, sort of demonstrating what's possible when patients and patient organisations are involved and empowered. I think for me, essentially, it's about not taking no for an answer and not accepting the status quo. So I'm going to wind back to 1998 when I was 33 years old, which kind of gives away my age. But I had a 1-year-old and a 3-year-old, and I was running the European arm of a global stockbroking firm. I absolutely loved my job. I was working very long hours, but I was really, really tired, which is understandable with a 1-year-old that isn't sleeping through the night. But I was also getting a lot of infections, and I started getting these ocular migraines and generally feeling really run down. And I remember describing it to my husband as feeling as though I was walking in treacle, or feeling as if my body was screaming at me. So I went to the doctor, thinking that perhaps I needed some vitamins to boost me. And after a blood test and then being referred to a haematologist and then having a bone marrow biopsy, I was told that I had multiple myeloma, which I'd never heard of, which normally affects people in their late 70s. And I was told that I had 18 months to live. And I remember thinking, one of the first things that I thought was that I wouldn't see my children start school, let alone university. And you can just imagine the impact that had. I mean, it literally blew my world apart. But before I go any further, I think it's really important to understand myeloma, why it's such a challenging cancer and what diagnosis and treatment looked like 25 years ago and the state of play now. So I'm going to hand over to Dr. Siv before continuing my story.
Thanks very much, Judy. So my name is Jonathan Siv. I'm a haematology consultant at UCLH, where I'm the service lead for myeloma. We have the largest myeloma practice in the UK. I'm also on the medical advisory panel for HI, so I've been involved in the charity, somewhat working with Adrian and co. So there's two areas that I'd like to address just to give a bit of context to the talk which Judy is going to be talking about. One of them is to talk about what myeloma is, just to give some context on that, and also talk a bit about some of the issues in getting drugs from those early discoveries through to patients. So first of all, what is myeloma? So as Judy said, it's a cancer that you may or may not have heard of, but it's in the same family of blood cancers as things like leukemia and lymphoma. And like all blood cells in adult life, plasma cells are produced in the bone marrow, and plasma cells are the types of cells which become cancerous and lead to myeloma. Now, the normal function of plasma cells in the body is to produce antibodies, and that leads to some understanding of the way myeloma acts inside the body. Go to the next slide, please. So you can see on this picture at the top, we've got healthy bone marrow producing healthy plasma cells, a wide variety of different antibodies which will protect us and provide good immunity against infection. And the second half of the picture is an illustration of what happens when somebody develops myeloma. One of these plasma cells will become cancerous and will lead to uncontrolled proliferation and an enlarged population of these cancerous plasma cells. And they're still producing an antibody, but now the antibody is effectively useless, and we call it a paraprotein. The one advantage for us is that it's a very good marker of myeloma. It's what we generally use to make the diagnosis and to assess people's response to treatment. If you go to the next slide. So how does myeloma damage the body? As Judy said, it's got quite a slightly unusual set of symptoms which can be difficult to diagnose. On the one hand, we've got this proliferation of these cancerous plasma cells inside the bone marrow. And because the plasma cells are there, that crowds out the production of normal blood cells, which can commonly cause anemia. So we're not producing the normal red blood cells that you would need. In addition, the proliferation of these plasma cells inside the bones can cause bone damage, which might lead to pain or even fractures and high calcium levels. On the other side, we can see what are the effects of the abnormal antibody or paraprotein that's produced by the plasma cells. So they can do a number of things. They can start to clog up the kidneys, putting people into kidney failure. If the protein levels are very high, it can cause thickening of the blood. That's a condition called hyperviscosity, which can be associated with strokes in some cases. And in addition, because we don't have the production of normal levels of antibodies, the infection risk goes up significantly. Next slide, please. So this can make it quite a challenging cancer to diagnose. There isn't a single lump that we're expecting people to check for. There isn't any bleeding or any other specific symptom that might prompt a trip to the doctor. Many of the symptoms that people describe are fairly vague. They might be varied. They might be the kind of common things that many of us get at various points. So some bone pain, some fatigue, infections. And this can make it very difficult for doctors in primary care, for GPs to make a diagnosis. So most people who go to their GP feeling tired, thankfully, do not have myeloma, but some of them occasionally will. And a GP may only see a case of myeloma once every 3 to 5 years. And it's this rarity coupled with the vagueness of the symptoms, which means that around a third of patients who have myeloma end up having to visit their GP at least 3 times before that diagnosis is made. Even when the blood tests are done, it may not be apparent for some time. I think just linking into what Judy's going to be talking about later about the work of Myeloma UK, it really helps one of the initiatives that's been put in place in terms of educating GPs, looking out for the early signs and knowing what tests need doing to make the diagnosis. Next slide. So how common is myeloma? Well, it's rare. It's rarer than some other cancers like breast cancer or bowel cancer that you may have heard of. But it's not so rare that many people in this lecture won't know of somebody who's had this condition. That around just under 6,000 people each year are diagnosed with myeloma, which leads to around 24,000 people currently living with myeloma in the UK. It accounts for about 2% of all cancers, but it's the third most common blood cancer. And as Judy mentioned, it's something that we commonly see in older patients. So the average age is around 65. Next slide, please. If we look at the statistics which show the incidence over age, we can still see that there's going to be a significant number of people who are younger than that, so in their 50s, 40s, or 30s. You can see the incidence going up, however, with age, and you can see that it's slightly more common in men than it is with women. Next slide. So myeloma, this plasma cell cancer, is characterized by a pattern of remission and relapse. So different cancers act in different ways. Every patient's cancer journey will be different. But myeloma isn't a cancer where we can say to patients, we can give you 3 months of chemotherapy and then it's cured. or an operation, then it's cured. However, it's also not a cancer where we say there's nothing that we can do, and unfortunately, this is terminal. We're in a situation where myeloma will tend to present, causing problems, but then it tends to be very responsive to what we'd call first-line chemotherapy. We'd expect around 90% of people with the highly active combinations that we have today to go into what's called a remission. And without being too miserable with our patients, we do have to emphasize that remission is not the same as cure. Remission means that the myeloma is no longer detectable, or it's detectable at an extremely low level, and that may well continue for a number of years. For most people, however, unfortunately, the myeloma tends to relapse. We can either detect that with a rise in that paraprotein level in the blood, or they may develop new symptoms. And when that happens, we would step in with second, third, or even fourth line or beyond line chemotherapy. What we tend to see, unfortunately, however, is that the duration of the remission decreases with each line of therapy. So whereas somebody may have their initial treatment go into remission for 4 or 5 years before the myeloma becomes active again, the second line treatment may last for a shorter period of time, 2 or 3 years, for example. That's not always the case. And with the new drugs which are coming online, we are seeing people who are having very long remissions, second or third relapse, but that tends to be the general rule. You can see on the left that we have something called asymptomatic conditions. So some people who are diagnosed with myeloma will know that they've got a pre-myeloma condition in advance. So these conditions are called MGUS, or smoldering myeloma. And in those patients, we may monitor them and we see myeloma developing and then step in when it happens. In other patients, they may not know they've got one of these precursor conditions, and the first thing they might know would be when they become unwell. And if we look on the right of that graph, we can see what happens when the myeloma becomes more and more resistant to treatment. It eventually becomes refractory. So now it's not really responding to any of the drug treatments that we have available, and that's when the situation becomes more difficult and we have very few options available to offer our patients. Next slide. Why do we get this pattern of relapse? Well, like any cancer, myeloma is driven by mutations which occur inside normal cells, which lead them to start proliferating and growing in an uncontrolled manner. So as extra mutations occur, you'll get more and more growth of this population of cancer cells. And within that population of cancer cells, we get what's called a subpopulation or a subclone of cells, which happen to be resistant to the drug that we're using. And you can see what happens on the second line of this picture. Once we step in with treatment, it might be a highly effective treatment, but it's still leaving a small proportion of cells which are still alive and haven't been killed off, and those are the ones that are resistant. And over time, that subpopulation or subclone of cells will grow and drive the relapse that we will see in clinical practice. So this is one of the challenges that we have in managing myeloma. We have good responses to start with, but then the cancer tends to become resistant over time. Next slide. So what's happened with progress in myeloma therapies? If we go back to the 1940s or 50s, when this entity was first really described, there were initial use of chemotherapy drugs like melphalan, which we still will use sometimes, and steroids, which we will still use. But unfortunately, there wasn't really very much progress for many decades. In the 1990s, there was the development of high-dose chemotherapy and bone marrow transplantation. It was only really in the 2000s when we started to get this stream of new drugs being discovered that were effective against myeloma. So some of the drugs there may be familiar to you, things like bortezomib, lenalidomide, pomalidomide. And Judy's going to speak specifically about the role Myeloma UK played in gaining access to 2 of those drugs, bortezomib and lenalidomide. The list, however, goes on, and this slide was actually about 10 years old. And it would, if you extended it out to 2024, there'd be even more drugs available, which brings with it its own challenges, as I'll mention. Next slide. And thankfully, this has translated to real progress for our patients. So these are survival curves, and they demonstrate how many patients are alive at each time point after their initial diagnosis. And it's showing serial survival curves for subsequent decades, starting in the 1970s. And we can see, if you look at what was the average survival in the 1970s, it's about 2.5, 3 years. By the time we get to the 2000s, that's extended out beyond 5 years. And I think we're currently looking at an average lifespan of over 7-8 years. So there has been significant improvement in the news that we can give to our patients, Unfortunately, we still don't have a cure for the vast majority of patients. The other point I'd like to make is when we talk about averages, that really conceals quite a lot of information. So there'll be some people who have much better outcomes than the average. They'll live for significantly longer than that average. Unfortunately, there are some people whose myeloma acts in a much more aggressive way, and they're not getting the benefits of these new drugs for whatever reason. And again, something else that Myeloma UK has looked at is trying to identify specific interventions for those patients by funding dedicated clinical trials, which is a real unmet need in the myeloma world. Next slide, please. So the other area that I wanted to talk about was something that's very relevant to the work of patient organisations like Myeloma UK, which was about the development, licensing and appraisal of new drugs. So as we heard last year from Professor Ruth Plummer, there's a lot of interesting work that goes on in drug discovery, early phase clinical trials, trying to identify which drugs are going to be useful. But unfortunately, there's still a long road ahead after getting that initial information before we can actually deliver those drugs to our patients. So we can see at the top, the areas that Ruth would have been talking about were the initial drug discovery work that goes on in universities and some of the initial testing which goes on. However, once there's been an initial response shown on early phase trials, we need to then extend that with much larger trials, looking at often many hundreds of patients to see if the new drugs are, number one, safe, and number two, they're effective, and number three, they're more effective than the existing drugs that we have. And there's going to be quite a high rate of attrition. Many drugs which look promising in an early phase of development will not eventually show that they are useful in the long term. Once we've shown that effectiveness or efficacy, as it's sometimes called, we then move to marketing authorization. So this has got nothing to do with price. This is just a decision which is made: has the drug got efficacy? Is it useful? Is it safe? And can it be manufactured in a qualitatively safe way? So those are the three things that are looked at: marketing authorization. In this country, since we left the EU, that's now carried out by something called the MHRA, Medicines and Healthcare Products Regulatory Agency. So at that point, the drug is now licensed and it can be used, but we still need to get it to patients. And for that, we've used NICE. So NICE, as I'm sure you're aware, is the National Institute for Health and Care Excellence. And they're the people who will make the decisions on the cost effectiveness and the access to treatment for the whole of the NHS. So there'll be numerous different stakeholders who will be involved in those decisions. There'll be the pharmaceutical company who might go in with an initial price. There will be health economists, there'll be clinical experts, there'll be patient groups, there'll be patient individuals who are giving their opinion. And all of this gets assessed in what's called a Health Technology Appraisal Committee. And that can take some time to work through and give a final decision. Sometimes we can have what's called interim funding by an organisation called the Cancer Drugs Fund. If the drug looks promising, they might agree to fund the drug while that decision is going through. But that funding can and sometimes is withdrawn if NICE ultimately makes a negative appraisal decision. Hopefully, however, we're going to get to a point that the drug is approved, and at that point, it becomes available. Next slide. So just to make things slightly more complicated, I work, one part of my job is in the UK Myeloma Society, which is a doctors group, and I have colleagues there from Wales, Scotland and Northern Ireland. And unfortunately, there are slightly different mechanisms in place in those regions of the UK. So even if NICE has made an approval, that will only hold good for NHS England. And there are different processes which have to be gone through in Wales, Scotland and Northern Ireland, which can make things even more complicated than they already were. Next slide. So where are we now? This was a slide that was put together by my colleague at UCLH, Dr. Neil Rabin. This shows the number of drugs that we now have available for myeloma. And you can see it's slightly in code. It might not be something that is intelligible to non-experts, but this really does show the large number of drugs that we now have available. And we've gone from that situation in the 1950s and 60s where we really just had very basic chemotherapy drugs and steroids. We've now got a plethora of drugs which are all funded by the NHS and can be used for our patients. One of the challenges that we're now grappling with is how do we select the right drug for our patients? How do we sequence those drugs? How do we combine them in the right way? I think that's a much better problem to have than the problem that we had before, when we had a real paucity of agents that we could use. Next slide. So in summary, I've talked to you about what myeloma is. It's a blood cancer that affects plasma cells. It has this remitting, relapsing course, which can be found in other cancers too. How we've had an increase in the number of drugs, and using those drugs has led to real benefits and improvements in survival. But the pathway from getting drugs from bench to bedside remains complicated and quite tortuous. So there's been lots of progress in this field. Many challenges still remain. And with that, I'll pass you back to Judy, who's going to be talking about her own journey and that of myeloma UK.
Thank you, Jonathan. So I'm going to take us back to 1998 and my diagnosis. And as you've heard, what really frightened me was that there was so little investment in myeloma research. So there were very little treatment options back in the day. Very little progress had been made compared to many other cancers. I quit my job with my future being so uncertain, and I reached out to the charity Myeloma UK, which at that point was in its very early stages of development, to see if I could help in any way, not knowing how, because I didn't have a background in charity or healthcare. I was asked to join their board, and I became chair a few years later. I've always been driven by a fundamental belief that one shouldn't just accept things as they are, and where change is needed, change must be possible. And too many people were reliant on change to give them a chance of surviving beyond 18 months. Too much needed changing in the myeloma space. At Myeloma UK, I discovered and fostered a very similar ambition, a total refusal to accept something can't be fixed, combined with an unwavering focus on patients' needs. So we were determined to create an end-to-end organisation that would cover everything to do with myeloma, from patient need to discovery and development, and then back to the patient to give patients access to new drugs. Our vision was extremely ambitious, as we were small and relatively unknown as an organisation, and our vision was considered impossible to turn into reality. And I'm not going to suggest that it was easy to achieve. It took years of building relationships with key stakeholders, industry, government, NICE, clinicians, nurses and patients, building collaborations and building credibility. And from the outset, I saw our role as a solution provider, meaning that we needed to identify the gaps and address the unmet needs of patients through funding, influencing and partnering. And accessing new treatments was and still is one of the key things that really matters to patients, and is literally the difference between life and death. So as I said, the charity was in its very early stages, but what we did at Myeloma UK over the next decade and beyond dramatically changed the landscape for myeloma patients. First slide, please. So let me focus on one of the first areas that needed fixing. As you've heard, there was an empty treatment pathway when I first became involved. So we focused our work to ensure that any potential new treatments would be trialled and then approved by NICE for funding. So you've heard that myeloma is a relapsing and remitting cancer, meaning that most patients will relapse multiple times. And speaking from a patient perspective, I can honestly say that not knowing if we're going to get access to an effective relapse is what keeps us awake at night. And we had a real sense of urgency at Myeloma UK, although we knew that we couldn't change things overnight. But we understood the disease, and we'd quickly learned and understood what was needed by NICE to get drugs approved. Interestingly, in 2004, 2 Israeli scientists won the Nobel Prize for Chemistry. Their work laid the foundation for a new class of drugs called proteasome inhibitors, resulting in a new drug, bortezomib, otherwise known as Velcade. And this was the first new myeloma treatment to be developed and licensed in this country in over 20 years. But in 2006, NICE rejected this drug on the grounds of cost. And from where I sat, both as a patient and leading our board at Myeloma UK, this was absolutely not acceptable, because we knew that the drug was available elsewhere in the world. We knew it was effective, and we knew that it would change the lives of literally thousands of patients across the UK. So our work was cut out for us at Myeloma UK. NICE had said no to Velcade on the grounds of cost, it didn't meet the required QALY, which is the threshold for it to be approved by NICE. Slide 2, please. The issue was around risk. The potential benefits of the drug were uncertain due to the way that the regulatory trial had been designed. And given its very high price at the time, NICE deemed it to be not good use of scarce NHS resources. We tried everything. Slide 3, please. All efforts to find a solution were failing, and this led to literally an 11th hour meeting and essentially brokering a risk-sharing deal. There was no roadmap for how to broker such a deal, and it had become a 4-year project. So the parties, the drug company, the NHS and NICE, agreed what was known as a Velcade response plan, containing an agreement that the NHS only had to pay for the drug if it worked for a patient, and the drug company would pick up the cost if it didn't. So this managed the uncertainty and risk associated with NICE saying yes. This deal meant that the drug met the criteria for funding, and it was approved to be prescribed on the NHS. So it was a win-win-win, a win for the drug company, for the NHS, and obviously for patients. And this was a first of its kind solution, and Myeloma UK had played a critical role. And it was a game changer for many, many thousands of patients, and for me, actually. And I can honestly say that if it were not for the work of Myeloma UK and getting this drug over the line, I probably wouldn't be here today. And over a decade later, Velcade continues to transform the lives of thousands of myeloma patients. But it was not without controversy, because we'd now entered new territory by interfering with issues around price, but we saw it differently. Up to that point, we hadn't been fully exposed to the flaws in drug development and clinical research generally, although we suspected that it was there. And it was clear to us that our role going forward should be one of an honest broker, as well as an organisation that needed to play a different and more strategic role in research and to the development of evidence that was needed, which included us setting up our own research through our own clinical trial network and collecting our own data through biobanking. Slide 4, please. As you can see, our role and our approach was endorsed by the then Chief Executive of NICE, Sir Andrew Dillon. And about 8 years after Velcade was approved on the NHS, when the Office for National Statistics published improvement in survival rates for all cancers compared to the previous 5 years, myeloma was at the very top of that list. You know, I consider charities to be run like businesses, and demonstrating impact is key for this. So for our donors, without whom we couldn't do our work, in my opinion, there wasn't any better way of demonstrating return on investment. The improvement in survival rates for myeloma had literally doubled. And that was just the start. Within 2 years, we needed to overturn yet another NICE rejection on the grounds of cost, and that was a drug called Revlimid. So we worked with the manufacturer NICE to deliver another new pricing deal, and Revlimid was approved. Again, this deal was a first of its kind. I think it's fair to say that Revlimid was a more high-profile case, but it came with similar issues. There was a huge amount at stake for the drug company, as its entire business model was built on generating income from Revlimid sales. So getting a no from NICE would have been almost fatal to the drug company. It was also hard to get approval for Revlimid, which we were trying to get through as a maintenance drug, given its very high price. And as a derivative of thalidomide, it was problematic due to the toxic side effect profile and its terrible history. So NICE's main driver for turning Revlimid down was again because it was not cost effective. It went to appeal, where interestingly the casting vote went to the appeal chair, who voted in favour of approval, which went against normal protocol, where in the event of a tied vote, the chair would normally vote against. The agreement that was approved was this time a treatment cap scheme rather than a risk sharing scheme, where Celgene agreed to pick up the cost of the drug after 26 cycles of treatment, which is approximately 2 years. Again, this was groundbreaking. Slide 5, please. So looking ahead, we saw the need to set up our own clinical trial network, which was not the norm for charities at that time. We needed to ensure that trials were set up to ask the right questions and to ensure that the data from these trials provided the evidence needed to get drugs approved for prescribing on the NHS. Next slide, please. Setting up our clinical trial network was a collaboration between patients, clinicians, drug companies and the NHS to help get myeloma treatments into clinic more quickly. So the network sought to create trials that responded to what patients and clinicians said that they needed. And the network supported 10 early phase clinical trials over 40 different sites. We then refined this approach more recently when we created the Concept and Access Research Programme, otherwise known as CARP. And this focuses on patient-centred trial design and delivering early phase clinical trials and ongoing access to new cutting-edge treatments for patients. Next slide, please. So let me highlight one example. You've heard about survival rates in myeloma today, and which have quadrupled from where they were in the 1990s. But even by 2017, it was apparent that many patients were not enjoying better outcomes from their treatment. And people with what we term as standard risk myeloma, those that respond well to treatments, usually have a first remission that is on average almost twice as long as for those considered to have high-risk myeloma. This means that high-risk patients remain in urgent need of better treatments. Next slide, please. Myeloma UK entered into a research partnership with the Institute of Cancer Research. And this work first applied genetic testing to patients to identify those at highest risk, and then involved co-designing one of our trials, MUC9, to use state-of-the-art molecular testing to understand where and in what combination treatments can be most effectively used, with a view to transforming treatment from a one-size-fits-all approach to a stratified approach driven by the disease genetic characteristics. So results from this phase 2 trial were recently presented at ASH, the American Society of Clinical Oncology, at their annual conference, and has recently published in the Journal of Clinical Oncology. This trial is the first to use state-of-the-art diagnostics and genetic profiling for this hard-to-treat group of myeloma patients. The trial asked the question differently. Who are the patients who need more intensive treatment combinations, and how can they be treated more effectively? The new treatment regimen was effective, showing that patients who received the new intensive treatment had a 99.5% higher chance of having a longer remission time than those who received the standard treatment. And the results from the trial are having an impact on a global level, sharing vital learning about how to treat high-risk myeloma. Slide 9, please. Another important and very relevant area of our work is the role that we play with clinicians. To say that we were not welcome with open arms in the early days is possibly an understatement, but we recognised the importance of collaboration and alignment and building trust. So as early as 2000, Myeloma UK began to influence how myeloma care was delivered and improve the education of healthcare professionals. So a lack of evidence-based guidelines meant that the patient experiences of diagnosis and treatment varied hugely. So we initiated work with the UK Myeloma Forum, as it was known then, and the British Society of Haematology to publish a series of recommendations on how myeloma should be diagnosed and treated. And those early recommendations became the national gold standard guidelines and are still used today. Slide 10, please. But guidelines on paper are nothing unless backed up in practice. And our Clinical Services Excellence Programme, which we call CSEP, recognises hospitals leading the way in myeloma care in the UK and supports those that need improvement. So accreditation for hospitals are secured through an extensive process, including auditing and assessing the services against best practice standards, as well as patients rating and giving feedback on their experience. They decide what a good experience feels like. And these awards are now highly sought after, and we're expanding the work with hospitals at an early stage of their improvement journey, and importantly with hospitals who don't have a specialism but wish to improve care. Next slide, please. So I'd like to pause here for a moment to talk a bit about late diagnosis. So when Myeloma UK began its work, it became very apparent that the lack of treatment choices was not the only driver of poor outcomes. People with myeloma were being diagnosed late in the development of their cancer because not enough was known about how to recognise its presentation. The reality of this rare cancer is that most GPs will not encounter more than an average of 2 cases in their professional lifetime. It prevents with largely non-specific symptoms, as Dr. Siv just mentioned, that can easily be viewed in isolation or as a symptom of simply just getting a bit older. Next slide, please. You know, we often say that diagnosing myeloma starts with a suspicion, and that's why we pulled our solution focus through to the earliest possible opportunity for intervention. So our early diagnosis program developed the first guide to myeloma for GPs. Next slide, please. And we've partnered with bodies such as BMJ Learning and Macmillan to get our resources into the hands of as many GPs as possible. We've developed tools for GPs and laboratories, all designed to suspect myeloma, test for it accurately, and to interpret those tests accurately. But even with this commitment, the challenge still remains. Half of patients face a wait of over 5 months to receive the right diagnosis. A third of patients visit their GP at least 3 times before being referred for a diagnosis, and around a third are diagnosed through an emergency route because their undetected cancer has seriously damaged their body. So looking ahead, 25 years on from where we first began our work, we're looking at different patterns of unmet need that we need to turn our attention to. Slide 14, please. So to inform our new strategy, in 2022, Myeloma UK conducted its most extensive study of unmet need and patient preference. We received an incredible 1,800 responses from this, and we were able to create, if you like, a contemporary map of where and how we could use our resources to take the next stride forward in diagnosis, treatment and care. And this has led to posters at ASH and BSH and are being used to inform our own service development. From this unmet need study, we've been able to see that our work over 25 years has created the conditions where people affected by myeloma could hope for and expect better outcomes post-diagnosis. Next slide, please. And with that came a new set of opportunities to apply our principles to preventing myeloma, treating myeloma, and living well with myeloma. So the first means that we can take a more far-reaching look at our diagnosis work, and whilst reconfirming our commitment to timely diagnosis in the present day, could begin to ask ourselves some questions about prevention. Is it possible to prevent myeloma from developing? Could screening be a way to identify people most at risk of developing myeloma? And how could we engage with a broader range of people to keep building our collective understanding of how myeloma develops and to spot it as early as possible? And then our second pillar, our second priority, treating myeloma. So we're never going to stop advocating for more choice in treatments and for more tolerable treatments for patients. But in looking at treating myeloma, we can also drill our focus down to where it's needed the most. How can we use our credentials in myeloma treatments to convene partnerships that lead to clinical breakthroughs and more personalised treatments? How can we improve the outcomes for high-risk myeloma patients, as you've heard about? And how can we shape the future for gold standard treatment and care? And the third area of focus, and one which I'd hoped for when we first began our work 25 years ago, but had no guarantee of seeing, is helping people to live a full life after a diagnosis of myeloma. So how can we better understand the biological and psychological impacts of living longer with myeloma? How can we be a catalyst for new maintenance treatments? And how can we make quality of life of everyone affected by myeloma, no matter who they are, where they live, their ethnicity or their income, one of the defining aspects of our work going forward? Next slide, please. So when I first became involved with Myeloma UK, I helped set its vision, and the phrase that we chose was "make myeloma history." For so many of the myeloma community at that time, it summed up their greatest hope. Even though too many knew that it wouldn't help them directly, they wished to see a world where no one else had to experience what they were going through. And today it's reassuring that so many still say that those words resonate with them. But the hope has changed. Many have a chance of living 10 years or more with their myeloma. And as the hope has changed, the concept of a cure has changed as well. We can now consider the potential of a functional cure and how we may get there, as well as seeking a clinical cure. And there may be multiple routes to making myeloma history. So I consider myself fortunate. Although my future is still uncertain, I've survived this far. My journey has included 3 relapses, 2 bone marrow transplants, and a number of different combinations of drugs, but I'm still here. I'm here to benefit from this era of novel treatments that they just didn't exist when I was diagnosed. But even today, at least 1 in 10 patients die within a year of diagnosis. There's clearly a lot more to be done, and we will continue to push for the changes needed to, the changes that are needed to ensure that every patient lives as well and for as long as possible. We firmly believe that no one agency or group can resolve the challenges on its own, and it's why we named our new strategy, Together We Are the Cure. Without the patient voice at the centre of decision making and design, the best efforts will miss the mark. We all need to give our expertise to the service of positive change. So as a disease-specific organisation and an end-to-end organisation that covers everything to do with myeloma, from patient need to discovery and development and back to the patient to give them access to drugs, we've created a blueprint that other charities have emulated. Slide 17, please. So here you can see what's been achieved, achieved through elevating and amplifying the patient voice. And our achievements are in no small part due to always staying close to the myeloma community. We understand the disease, we understand the issues that patients and clinicians face, we understand who can make change happen, and we're unafraid to work in new ways to get things done and offer new hope to patients. We've always asked ourselves, if not us, then who? And that has created impetus for change and challenge through all aspects of myeloma treatment and care. So since Myeloma UK was founded, we've invested over £19 million in research, asking the questions that matter to people affected by myeloma. I think Myeloma UK's journey and my own demonstrate that it's not one single element that results in the best outcome for patients. It's a combination of good science, good trials, in other words, the right trials asking the right questions resulting in access to better treatments, earlier diagnosis, strong support for patients and carers, and equality of treatment and care, plus, and possibly most importantly, a strong community working in collaboration and partnership. So as I mentioned right at the beginning of this lecture, putting the patient right bang in the centre of decision making is what's made progress possible. Myeloma UK has often been referred to as punching above its weight, and hopefully I've been able to demonstrate that together with the myeloma community, we've shown just how much can be achieved when you refuse to take no for an answer. Thank you very much, and I think back to you, Adrian.
Thank you very much, Judy, and also thank you, Jonathan. That was absolutely fascinating, but also it's difficult to find the words to say how amazing that those talks were. Thank you very much. For the audience, if there's any comments, anything anyone wants to ask, please write them in the comment box, and then we can bring them up with Judy or Jonathan. And I think what I want to ask Judy and Jonathan, have you any questions you'd like to ask each other? Being both of you experts in the field, but experts from a different perspective. Judy to Jonathan or Jonathan to Judy? There, I'll put you on the spot now. I'd like to ask.
I guess I'd ask Judy sort of the
Go on. Go for it, Jonathan.
I was just going to ask about clinical trials, because I think we're always beholden to the results that come from clinical trials. But they're obviously very hard and expensive to run, and it's sort of
we've lost him.
I can sort of, I don't know what he's going to say, but one of the questions that I do get asked a lot is about the stigma around, trialing new drugs and the risk. And why it's so hard to recruit people onto. Sorry, Jonathan, I was filling the gap here. I don't know what you're going to ask, but what I'm answering, if it's not the same thing, please come back. I think that there are a lot of patients that are nervous about taking part in clinical studies. The way I see it is that I wouldn't be here if people hadn't taken part in clinical studies prior to me. And I see it as an opportunity. I mean, obviously, trials don't get to patient stages unless they're safe. But I see it as a real opportunity. I mean, I know with myeloma, there's trials that are going on right now, and there's drugs that we're now getting access to, which are game changing for patients. That further down the line, I think, as Jonathan, when he was mentioning, high risk myeloma, people they're really turning patients around at a much later stage in their disease journey. So, Jonathan, I'm sort of waffling to fill the gap, but I'm a huge.
Sorry, I think that was fine. I'm sorry I cut out, but that's great. Thank you.
And I think that the message that you're giving, Judy, which I think a lot of us are aware of, if you're offered to be in a trial, I think the message is go for it, because number one, no trial is done and you're going to do worse. You're going to be in perhaps two groups or whatever, but actually you'll be closely monitored. It's a good way forward. It's a good thing to be in a trial.
Yeah. And you can always
trials do better. Absolutely right. Absolutely right.
Yeah, so I'm extremely grateful to patients that have come before me because of the drugs that I've had access to as a result of them. So, yes, big fan.
Yeah, and I think so. And I think the other thing I wouldn't mind just mentioning before we wind up is, how do we get GPs to pick up this earlier, or with artificial intelligence and Google Doctor, etc., are people going to pick up their diagnosis earlier? Is that going to influence? This is just a general thought. Yeah. So sorry to mention it, but
I mean, I think it's difficult. I think, speaking as someone who's a specialist, we normally see patients when the diagnosis has already been made. It's very easy with a retrospectoscope or looking back saying, well, obviously that was a myeloma diagnosis. How could they have missed it? But our GP colleagues see many patients who've got fatigue and a bit of ache and pain and a couple of colds over the winter. So it's very difficult. And you may well be right. It may be one of those things where putting together all those subtle cues is something that could be done by an AI type algorithm, but I'm speculating mildly here. But it's the kind of subtle distinction where there isn't a hard sign there where it could play a role in the future.
Yeah. I mean, AI and medically unexplained symptoms is something that is being spoken about. Yeah. Judy, do you want to add anything before we wind up?
No, I think it's osteopaths as well, remember, because people often, have all sorts of bone pain and aches, and, so it's not just GPs, but, we ran a campaign at Myeloma UK a few years ago, which was about trying to get patients that were going in with an ingrowing toenail, let's say, to present a diagnosis pathway to their GPs, put it in their hands, because things often don't reach the GPs. They kind of get stuck before they get to them. So, there are a number of, and we have, a whole group of people that's led by one of our trustees at Myeloma UK, looking at how we can help GPs diagnose earlier with different tools that we provide and strategies.
Yeah, because I think if you can teach GPs, in inverted commas, find a technique, look at a way of helping GPs come to a diagnosis with myeloma, that will actually impact on other cancers as well, other illnesses as well. Just a couple of questions. There's a question here: how early should treatment start if a patient is on the cusp of myeloma but completely asymptomatic? We may not be able to answer that because we've lost Jonathan on the call. I don't know if you want to say anything at all, Judy.
Well, there is some work looking at, in fact, the new strategy for Myeloma UK is looking at intervening earlier. So some of the preconditions like smouldering and MGUS, and whether there's a benefit. So that's part of the work that we're doing. On the cusp is difficult because if you've got smouldering myeloma, you're going to need to be treated. It's not one of these, situations where if you watch and wait, it may never happen. So it can come down to the individual preference. And I think I know who's asking that question.
Okay, I'm going to wind this up now because I'm conscious of time, and we're just over the 9 o'clock. So first of all, a few comments in the chat box saying that was amazing, and actually I have to agree with you. Great, good information, lots to learn, and lots that can be learnt in other areas and other disease-related areas, malignant disease-related areas. So, Judy, Jonathan, thank you so much for preparing that and speaking so eloquently on the subject. Thank you. Can I also mention one other thing, which I think is important to mention today, is that Lisa Steele has worked with CHI for 23 years and is retiring in the probably early next year. And I think it's important just to say how much Lisa has contributed. She's been an amazing person working for the charity and doing amazing things for the charity. But I think people should be aware that Lisa will be retiring next year. So we can use this as an opportunity to say, Lisa, thank you so much. She'll still be involved with CHI, she'll still be working with CHI, but she will not be in the role that she's in at present. And may I also thank you all for joining the call today, and thank you. Please all keep well. I think the next one's Hanukkah, isn't it? So have a great Hanukkah, and please keep in contact and support CHI. Thank you very much indeed.